Welcome everybody, and welcome to another of GIEQs webinar. It is our fantastic pleasure tonight to be joined by Professor Leon Moons from the Netherlands, who needs, I think, very little introduction, although we'll do an introduction. And the theme of this webinar is T1 colorectal cancer. Is quality really in polypectomy? Is really the journey that that country has gone through, primarily led by this working group, of which we are, I think it's fair to say, Leon, in most countries, extremely envious, and would like very much to hear about the high quality publications coming out of your group, about how you've got to the point that you're at. So that's the ask. I'm joined by my co-faculty tonight, Dr. Roland Valory from Cheltenham in the UK, and Dr. Lopke de Zomer from Roeselare in Belgium. So without further ado, why this webinar? So we've done a lot of webinars this year. This is actually one of the last ones. And the point of these webinars is to introduce some of the faculty that will be coming to see you at the sixth even, edition of GIEQs in September. And also to really highlight some of the aspects that we find critically important in terms of quality in endoscopy practice, and not just quality in the niche of endoscopy practice, but really quality in the everyday. And polypectomy practice, the detection of cancer within colorectal polyps, high quality polypectomy, and the interpretation of histopathology, all of which you'll hear about tonight, are really critical decision points in polypectomy practice, and things which are often done less than perfectly. And so hopefully tonight we can hear about some of the evidence, the methodology, and discuss the further implementation in countries which are not quite as advanced in the Netherlands in all these points. To introduce Leon, welcome so much, and thank you so much for joining us, Leon. We're really, really very grateful. Leon is a professor of GI endoscopy in the UMC Utrecht, chair, I think, of the Dutch T1 colorectal cancer working group, has published a lot on these topics: optical diagnosis, EMR quality, T1 colorectal cancer, resection techniques, and actually, for me, some interest, and not really covered tonight, but something you should go and look at, about the follow-up of colorectal cancer, endoscopically or surgically treated, and what exactly it is that kills patients, and what exactly that says about what therapy that we're doing. A significant advocate, I think, and this is why the GIEQs connection for community hospitals, general endoscopists, and the impact that centralization might have on that. So Leon, welcome. Thanks so much for joining us. Did I get something wrong in the introduction, or did I say everything right?
No, too much honor, too much honor. I'm really, I want to thank you for the invitation, and it's always nice to have an opportunity to discuss among colleagues about our new insights and our thoughts, and it's always also good for me to get some critics. So please be open and share your enthusiasm, but also your critics and maybe your second thoughts about what we are doing.
Perfect. Okay, well, just before we get started, we have this interactive platform. Now, I'm not sure how many people, Leon made the point, it's sunny outside and everybody's maybe out in the sun, and maybe this live interaction falls extremely flat. But you can join via this QR code, and we'll start the presentation of it, and I will screen share it. So if you are at that QR code, you should already be able to see the first question. And actually, I'm just going to read it out and show it on screen, because I think that it's an interesting one. So I will share it now. You should be able to see it. Just one sec. Can you see the slide? Yeah? Yeah, okay. So the question is, in your practice, which step of T1 colorectal cancer care do you believe causes the greatest patient risk? Is it that people don't optically diagnose the lesion? Is it that once they've done it, maybe they think, oh, okay, we'll go ahead and resect it, and unfortunately, they cut halfway through a colorectal cancer, and then that means there's no oncologic result? Is it that the intervention that they do causes procedural complications?